Good evening. I would like to welcome Dr. Mohit Sani. He is director and involved in the academics in the Institute of Child and Nirmal Hospital and Private Limited, Surat. He is the founder of Neonatal Focus Eco Academy, and as I feel he doesn't need an introduction because he is the one who is spreading this focus in neonatal echocardiography and point of care ultrasound all over India and abroad. So he is the editor-in-chief for the Journal of Neonatology, and he's quite known for his neonatal hemodynamics and point of care ultrasound, and especially neonatal echocardiography. So let's hear from him. He will highlight a few points. I know this hardly 15 to 20 minutes are very less to elaborate, but I know he will definitely do justice within these few minutes.
Thank you, Dr. Sudhir. Can you switch off? Yes. So in this, basically, my duty for next 15 minutes is to highlight why the focus or the functional echo is important and useful. It may or may not. That all depends when you use the product. So it is not something like that in the heart, the heart में मेरे को आपका आत्मथिक ज्योति नहीं जलाने आया हूँ. I am not here to burn the light of enlightenment. But yes, there are few things which may be important for us. I just wanted to ask you people, what are the poll? Start with the poll. Which are more common, acyanotic or cyanotic heart diseases? Who is for acyanotic heart diseases? For cyanotic? So that's one thing. Whenever we talk about neonatal echoes, the whole thing moves on to one thing, that whether there is a congenital heart disease or not. But the neonatal echo congenital heart disease is just a part of that. Because the functional assessment is much more important for day-to-day management as compared to just identify whether there is a congenital heart disease or not. And that is what this thing shows. So whenever there is an anatomical problem, yes, there is a cardiac issues, but most of our things are rotating between functional, evaluation and hemodynamics problems. So that is what we will discuss. So what can be the hemodynamics problem and issues in the preterm baby? Anyone? Any one problem in preterm hemodynamics? Just utter a word. Okay. So that is, first is from the transition, RDS, PDA, shock, all those things. So it is not just concise to the heart only. There are other structures and other systems which are getting involved. Head ultrasounds, line placements, everything is being involved. So that is what is our focus echo is. That is, we focus and target the treatment. And it is not only the congenital heart diseases that is in our pursuit, that we have to keep in mind. Because most of us will be having the neonatal ventilation in our unit. We are doing neonatal ventilation. But how many of those ventilators have got graphics? But that doesn't mean if you don't have graphics, you don't ventilate the babies. It is just for optimization of the ventilation. Similarly, your functional echo or focus is not there. That it doesn't mean that you don't have ultrasound machine, you won't treat a baby with a shock. You will treat. And this is what is being highlighted by Dr. Wazir also. But it just optimizes the approach. That is there, that focus echo is there only to optimize your approach. So it doesn't mean that if you do focus, you are a Superman. Because if you are a Superman also, you do have the limitations. Even the Superman has the limitations. So that we should keep in mind. So let's discuss one scenario. This is 35-weeker, 2.5 kg with birth, tachypnea at birth and cyanosis. With 4 hours, the tachypnea and cyanosis increased. So it was intubated and FiO2 was 100% on ventilator, and SpO2, which was initially 65%, increased to 85% post ventilator. So the X-ray was being done, so complete whiteout of the X-ray. So diffuse haziness, so was diagnosed as a 35-weeker, maybe the RDS, so surfactant was given, till 6 hours post surfactant, there was no improvement. So what was the next thing? What we should have done or we should do in these babies? Second dose of surfactant we should plan, do an echo or review the baby after 6 hours if baby is even started maintaining saturation. Anyone for A? Want to give second dose of surfactant in this baby? Anyone? Okay. Who is for echo? 4 hands. Okay. And review after 6? Okay, the thing is, if your baby is nearing the term, was not maintaining saturation, there are many other aspects. You're given 1 dose of surfactant, nothing has changed, then I would more go, my brain would go more towards the cardiac issues. Okay, so I would like to do echo before deciding the second dose of surfactant. That is very important. Otherwise, the same will be the scenario even after giving the second dose of surfactant. And if you are delaying, and suppose it is a duct-dependent lesion, and you haven't started any prostaglandins, not done an echo, then the baby may not be there after 6 hours also. So you should be see. So the word from the horse's mouth only. So what Dr. Bazir sir is saying, even before giving first dose of surfactant, he would like to do an echo. And that is, if it is there, lying there, yes, that would be my first approach. Very much right. So this is that 38 weeker with birth weight of 3.5 kg, day 3 tachypnea and cyanosis, right hand 84%, right foot 74%. I have brought this case to stress upon few vitals which are very important. Whenever we are talking about saturations, don't do saturation anywhere. Always try to do saturation on the right hand, that is your preductal, and then compare it and do it on any of the lower leg. Preductal, postductal saturations is very important. Whenever we are talking about blood pressures, always tend to do 4-lane blood pressures. Make it a habit. And now perfusion index has also been, because that tells you how the baby is going, how the baby is moving, whether the baby is going into shock, that gives you a trend. That is very important. And that clinically only you can make out whether it is because of respiratory cause or the cardiac cause. So that one clinical idea helps you even if you are doing an echo also. Most of the diagnoses before I do an echo, most of the clinical diagnoses are there in my head. And that's how you will be able to make quick diagnosis even after doing an echo. And if you don't know, don't have the idea, you may miss even the major anomalies also. So that is very important. So the baby worsens with the crying. Oxygen by prongs 2 liters per minute ventilated after that. ABG in the right hand was done after 10 minutes. PO2 is 80. CFT is being stabilized. Okay, 3 seconds. Hyperoxia test nowadays is an obsolete thing because if you are an early echo done, then the hyperoxia test doesn't matter. But if you are doing this, baby fails hyperoxia test. Okay, so all these things indicated that this is more of a cyanotic congenital heart disease. First presentation is cyanosis, respiratory distress. That's why it pronounced more to be a right-sided obstructed lesions or can be a very severe BPH. And now the role of echo comes. Till this point, I have made the clinical diagnosis. Now I have to be very sure and systematic, so I will get an echo done. But if you strongly suspect in this baby that this is a right-sided duct-dependent lesion, please have a very low threshold to start the prostaglandins, even if the echo is not available. You can anytime stop prostaglandin, it will not harm. At the max, you need to ventilate the baby. But if you don't start prostaglandin and wait for an echo, the baby may die. So that is one message I would like to pass on. And this is what these kind of babies, they may present like this. This is 28 weeker infant, 1 kg, 1 dose of surfactant given, admitted in level 3 NICU, started on having increased oxygen requirement and hypotensive at 12 hours of life. And as you can see, on admission, yes, that diagnosis, that blood pressure, which was being given to us by 12 drunkard neonatologists in a bar of England, that has been maintained. But since then, after passing hours, you can see the blood pressures are going down. the heart rate is going up, pH is going down, base deficit is increasing, lactate is increasing. And typical, like initially the baby was ventilated, then after observation the first bolus was given, blood pressure still low, dopamine was started, blood pressure still low, FID requirement went up, dopamine was increased, dobutamine was increased. So this is what we taught, and we have been taught like that to have a protocol approach. But this is not true, as being pointed out by Sanjay Vijay sir also. So this baby is not doing fine. The first and foremost thing I would choose is, I would ask for an X-ray chest and rule dope. The basic things has to be ruled out first before going for echo and all advanced investigations, because this baby may have a pneumothorax. We have to rule out that. So first rule out dope and then go for other things. And regarding the inotropic sport, there are a lot of other things we need to. So when the echo was being done in this baby, there was a hemodynamic significant PDA, that is the red jet what we are seeing. So in this, you may go up to 30 mics per kg per minute of dopamine, your hypertension will not be relieved. So the only way you can treat the hypertension in these babies is by treating the duct. So that's when the role of echo comes in. So in our unit, whenever the baby is on moderate dose of one inotrope and we need to add another inotrope, it is a dictum to get an echo done before or while adding the second inotrope. That is very important. So that approach you should keep in mind. Same preterm baby, 28 weeks, second dose of surfactant was given because baby deteriorated, but now well, was extubated on high flow cannula, 21% FiO2, 10 ml every 2 hourly EVM is been tolerating. Day 4 became lethargic with mottling, and septic workup was done, which was positive. HSPDA was there, was treated for same, but developed seizures and lethargic. So now the role comes that the issues are, it may be sepsis, meningitis, dyselectroitemia, IVH. So IVH in 28 week or 1 kg baby, we have to assess that. That is very important. So now again the role of ultrasound comes in. Because, so there was a grade 4 IVH. So in that, you have to prognosticate. One, it gives you the cause, when the baby became sick. Then it targeted your treatment. Third thing is, you can do the prognosis. So that prognostication is very important in these babies. You can explain to the parents whether we should continue with the treatment of this baby or they want to do the withdrawal of sport. So that's how it becomes, the ultrasound probe becomes handy for you. Another baby, 26 week, 800 grams, born to primary, cried, but developed RDS, steroid covered. Delivery room CPAP was started, was shifted to NICU on CPAP. 6 cm FiO2, 40%. Vitals pretty okay. Started having desaturation, developed mottling and became off color. So what are the reasons of deterioration? Again, we have to rule out the initial HMD worsening, dope, IVS, shock, all these common things, all were ruled out, but still the perfusion is poor. Okay, so in terms of management, would you give the bolus to this baby? Yes, no, it is debatable. But even if after giving one bolus, the baby has not improved, you will think about inotropic sport. Which one to choose? Again, there was a, like Dr. Sanjay Vijay pointed out, dopamine to glutamine is now kind of, old-fashioned things now we say, because, but a lot of studies are coming up, still we don't have the randomized controlled trials for that. But this is what we have been taught till now. The only thing which has been added is echo, functional echo. That too after a few steps, when we follow this protocol approach. So I would say is, shock monitoring is like, we do clinical, we do vitals, and then we do this lactate, ABG and functional echo is added into this. So in this baby, we added on the flavor of functional echo. Preterm 30 weeker, birth weight 1.4 kg. Day 3rd, CPAP is 30%, increased oxygen requirement, started having apnea, CFT is bit prolonged, 4 seconds. Pulses, they are full in all the 4 limbs, full pulses in all the 4 limbs. Heart rate 150, SpO2 is 90%, blood pressures are normal for the age and gestation, sepsis screen is positive. And now you see the echo. Structure is normal, LA-LV is normal volume, so there is not hypovolemia. Contraction is good, So that means your cardiac contractility is good. So it is not myocardial dysfunction because your fraction shortening is normal. LVO, left ventricular output is 340 ml per kg per minute. That is high. Anything more than 300 is high. IVC is high volume. So it is hypervolemia. Okay, so what you are saying is baby with normal blood pressures, perfusion poor, normal blood pressures, in echo you have got high output. So baby is in high output failure. And the most common cause for that is sepsis. And this is what septic shock is. So therefore, with combining clinical information with the echo information, you are able to make a physiological diagnosis. And if I ask you what treatment you will give, yeah, so you will try to give vasopressor in this, yes. So this is what it is. Bolus, again yes and no, but inotrope, my choices are, I shortlisted that. Norepinephrine, epinephrine and early steroids is the trend to treat ELBW or preterm babies with shock, with sepsis. So that's why whenever your babies are in shock, in sepsis and shock, you have to divide it whether it is high output or low output. Even though nowadays, previously it was dopamine and dobutamine in both the cases, but nowadays low dose epinephrine is the drug of choice. So that's why that debate of, we know the cause, but now the drug is being very common. And that common is epinephrine, because that is being widely used. The only thing is, in high output septic shock, you may prefer norepinephrine before epinephrine, and many units they use that. So it all depends on it. So this is how your approach changes with the functional echo. All concentration is on the cardiac output that we do. So that's how we change our approach, whether impaired contractility is there, hypovolemia is there, and if there is a PDA,